Dr.
Can you see
Barasa?
the slides?
Hello? Dr. Barasa?
Oh, sorry, I think, yeah, my volume was low. So you can, right?
Yes, we can see and hear you. Thank you.
Okay, so today we're going to look at primary immunodeficiencies. I'll try complete the lecture today, and then I'll send you some reading material for tomorrow with a bit more detail. I won't be able to teach tomorrow because I'll be at a conference. The annual pathologist conference is actually set today. Okay, so just as an introduction, immunodeficiency is basically a failure of the immune system to protect the host against infections. So clinically, this is going to manifest as an increased susceptibility to infection. So these are people who basically have recurrent infections or more than usual severity of infections, or infections with opportunistic pathogens, which usually would not cause infections in an immunocompetent host. So the recurrent infections would be the unusual frequency or the severity. So immunodeficiencies can be primary, which means that one is born with the already dysfunctional immune system. So that's congenital. Or it can be secondary, meaning there's an underlying cause. So this would be an acquired cause. Generally, secondary causes of immune deficiency are more common than the primary causes. So even when you interact with these patients who you may think are having very many infections and it would be unusual, it would always be good to rule out an acquired cause before you start thinking of a primary immunodeficiency. So primary immunodeficiencies, as we mentioned, there's an inherent immune defect. So there's a problem within the immune system itself, as opposed to a secondary or acquired cause, where it could be something else like an infection, for example, HIV/AIDS, or it could be some medication that interferes or like causes immune suppression. So the defect is not within the immune system. So currently, the nomenclature of primary immunodeficiencies, which we also call PIDs, is changing, and more people are starting to call them inborn errors of immunity. And I think that name is it's straightforward. It just means like it's an inherent defect in the immune system. So as I mentioned, there are, okay, hold on. There's a class rep looking for me. Let me just speak to her. Okay, so they are rare, but it doesn't mean that they don't exist. They're actually commoner than we think. I guess we, meaning immunologists worldwide, or people who deal with patients with immune defects. So worldwide, if you combine all of them, so there are very many disorders. Okay, about 400. So as a group, the worldwide prevalence is about 1 in 1,000. So that is quite common. That's even more common than hemophilias. Okay. And actually, they say these defects are 10 times more common than hemophilias. It's just that a lot of the time, they probably go undiagnosed because of lack of awareness. Regionally, they tend to be more common in certain parts of the world, especially where there's a lot of consanguinity. So like in North Africa, we talk about Sudan, Tunisia, Morocco, they have quite a number of these primary immunodeficiencies. In the Middle East. But then they've been described in other parts of the world, in the Western world, in Europe, in the USA, in Africa, so sub-Saharan Africa, South Africa also have a big registry. The awareness in Kenya and I guess the rest of East Africa has just started taking root maybe a couple of years ago. So we do have a few patients that have been diagnosed. So they do exist. In terms of the prevalence, when you look at individual diseases, there are some that are more common than others. For example, selective IgA deficiency is quite common, with a prevalence of 1 in about 200 individuals, so very common, but it's just that it tends to be very benign. So, won't manifest as severe disease. In fact, most of the time, it tends to be an incidental finding. So these patients usually present with usually GI symptoms like celiac disease, and then as they're undergoing evaluation for that, incidentally, they're found to have an IgA deficiency. The most severe form of primary immunodeficiency is called SCID, that is severe combined immunodeficiency, and that one is quite rare, with a prevalence of 1 in 58,000. In terms of classification, just to make it easier, to group them and remember them, broadly they're classified according to the immune defects, and I'll take us through the most recent classification, which I think is just about to be updated. It's updated every 2 years. Most of the time they're diagnosed in childhood, so most of them will manifest in childhood, but I guess because they're congenital, but there are some which can first manifest in adulthood. Okay, this chart just shows the difference between a primary and a secondary immunodeficiency. As we mentioned, for the primary immunodeficiency, it's inherent to the immune system, so it's an intrinsic defect with any component of the immune system, whether it's the innate immune system, for example, your complement or your phagocytes, or the adaptive immune system, where we're talking about our T or B lymphocytes. And the defect could be in an enzyme, it could be a certain cell type that is missing, or just a component that is not functioning. And as I mentioned, the presentation can be from early childhood because it's congenital, but the manifestation can also occur later, either in later childhood or even in adulthood. For secondary immune deficiency, it's an extrinsic defect to the immune system. So usually an underlying disease, or another factor, for example, some sort of treatment that would cause immune deficiency, like chemotherapeutic agents, like cytotoxic drugs, or even radiotherapy. Underlying disease could include infections, could include malignancy, malnutrition as well. Actually, they say malnutrition is the most common cause of globally of immune deficiency, of acquired immune deficiency, even more common than HIV/AIDS infection. Okay, so the PIDs, or inborn errors of immunity, are a heterogeneous group of disorders, and that's because you can have a defect of any component of the immune system. All the components that we discussed in second year can actually be defective. Okay, so there's poor or absent function in one or more of these components. Sometimes you get, like, when you have a certain mutation, it would affect maybe more than one component. Sometimes it's just one component that is involved. And as mentioned before, this predisposes these patients to an increased frequency and severity of infection. So even as much as we talk about the fact that we're in the tropics and infectious diseases are endemic, it's, there's a cutoff at which you would think these infections that this patient is presenting with are more than usual. Okay. So the most common manifestation would be the increased frequency and severity of infections. But remember, every system in the body has to be regulated. There's always, the aim to maintain homeostasis. So there can also be a defect that would present as immune dysregulation. Okay. So this could manifest as autoimmunity, so predisposition to autoimmune disease. In these patients with primary immunodeficiency, they tend to have more than one organ system involved in the autoimmunity. Okay, it could be predisposition to allergy, abnormal or aberrant inflammation, and lymphoproliferative disease. So those are the other manifestations of primary immune deficiency. Okay, so for the secondary immune deficiency, usually the major manifestation would be just the increased frequency and severity of infections. However, I think you know that in AIDS, there's also a predisposition to lymphoproliferative disease. So currently, in terms of the number of diseases or disorders, there are 406 distinct disorders defined phenotypically. So that is either by the clinical manifestation or the laboratory test that would actually, show that these are 406 distinct diseases. But when it comes to the gene that is affected or the genetic mutation, there are actually 430 defects. And these primary immunodeficiencies are single gene defects, so they're monogenic disorders, okay? So I mentioned that they're classified according to the immune defect, and that is both, they try and combine the genotypic plus the phenotypic findings just to make the classification easier. So I don't need you to remember, the details of the classification. I'll just give you, what they have broadly as the groups of the disorders, just so that you can think about this more and you can have a way of approaching patients you may think present with such manifestations. So in terms of the pathogenesis, they're monogenic disorders, so a single gene defect. This picture just highlights a few of the disorders that generally affect lymphocytes. But remember, I mentioned that any component of the immune system can be involved, including the innate immune system, whether it's phagocytes, whether it's your cytokines, whether it's complement. Okay, so this is just to give you an example of some of the PIDs. And here we're looking at lymphocyte development. If you remember your ontogenesis of your B and T lymphocytes, remember these cells are produced in the bone marrow. The B cells will mature in the bone marrow, while the T cells will exit and go and mature in the thymus. Okay, so if you have an arrest in or differentiation of your lymphocytes, you don't get your pro-lymphocytes from the lymphoid stem cell, then obviously there will be no B or T lymphocytes developing. Okay, so that will basically manifest as a severe combined immunodeficiency. So combined because no B cells, no T cells, okay? If, for example, you get your B cells being arrested in the pre-B stage, so they don't mature any further, usually there would be a certain, remember when these cells are undergoing maturation, the major events that occur would be, rearrangement of the genes that encode the receptors, so that at the end of the day, when you have your mature B or T cell, you actually have a cell that expresses a functional receptor. Because for these cells to be functional, they need to interact with antigen through their receptor, whether it's the B or the T cell receptor. So any event that would interfere with signaling, so in this case for your pre-B cell, where you have your pre-B receptor, where only the heavy chain has been rearranged, then you do need, remember that as the cells are maturing, they receive growth factors as signals for them to be able to go on to the next stage. So there's one of the signaling molecules is the tyrosine kinase that is called the Bruton's tyrosine kinase. So if there's a mutation in that at the pre-B stage, in the gene that codes for that, it's called the BTK gene, then this pre-B cell will not mature further. So it will be arrested at this stage. And this is the patient who will present with that disease entity called X-linked Hypogammaglobulinemia. So it's X-linked, as the name suggests. So usually the carriers would be the female parent, and usually will present in boys. And they are agammaglobulinemic, meaning they actually will have absent antibody production because they do not have any mature B cells. Okay, so that's another example. Sometimes you can get a SCID because of problems with some of the cytokines, and I think I hope I have a picture that can just put that into context for you. So there's one of the chains that forms the cytokine molecule, which is shared commonly amongst various cytokines. If you have a defect with that cytokine or its receptor, then you don't have signaling with of these cells, so they cannot differentiate further. So that can present as SCID, and it will affect both the B and the T cells. And I'll show you a picture of that. When it comes to the thymus, where you expect your T cells to develop, if you have any gene defects that would affect or interfere with that, then that will ultimately present with a SCID. The other thing is, if you don't, an abnormality, for example, with formation of your major histocompatibility complex proteins, so you end up having cells that do not express MHC on their surface, especially if you talk about the antigen-presenting cells. So this would manifest with what we call a bare lymphocyte syndrome. Let me see what else. For your mature B cell, we know the major function of your B cell when it's been activated is to differentiate into a plasma cell that would secrete immunoglobulins, and we know the different isotypes. So sometimes you can have a selective deficiency of one of the immunoglobulin isotypes, like I already alluded to, selective IgA deficiency or IgG or IgE. So it's not really known what genetic defect would cause these selective deficiencies. They probably think there's more than one defect, and usually these patients will present with a disease entity called common variable immunodeficiency, which I'll also allude to later. So I think the take home here is just to know that these are monogenic disorders. So for, regardless of the manifestation, phenotypically, usually the underlying problem is that there's a certain gene that is involved in immune function that is mutated. Okay, so this is the 2019 classification of PIDs. I think they classify it into 10 groups. The previous one was 2017, where they had seven groups. They're currently, IUIS is the International Union of Immunological Societies. So they update the classification every year. So probably, and it's done every 2 years. And they're probably finalizing on the new one. Usually the classification comes out about December. So probably December 2021 or January 2022, we'll have the latest classification. So they're generally 10 broad groups. So I'm just going to touch on a few examples in each of these classifications, and probably give a bit more detail in terms of the pathophysiology for some of these diseases. As I mentioned, there are very many disorders. We've seen 430 gene defects, 406 distinct diseases. So it's difficult to remember all of them. But there are some that are probably, I think, I would like you to know about. So the first group is a broad group of many disorders, but generally they're called immunodeficiencies that affect cellular and humoral immunity. Okay, so this is the group that is basically called the severe combined immunodeficiency, or SCID. So as the name suggests, it's combined because B cells are affected, T cells are affected. And you can see, as the classification title suggests, cellular and humoral immunity. SCID is defined by a T cell lymphopenia. Okay, so usually when you enumerate these patients' lymphocyte subsets, the T cells, which are defined by elaboration of CD3 on their surface. So, and usually we use flow cytometry, and I think you've gone through the principles of that to count these cells. Okay, remember your Coulter counter in hematology will give you a total lymphocyte count. So if you want to know out of this lymphocyte, how many are B cells, how many are T cells, how many are natural killer cells, you would need to use monoclonal antibodies against the specific markers for these cells. So all T cells elaborate CD3. B cells usually would use CD19 or CD20. And for natural killer cells, we'd use CD16 and 56. So on enumerating the T cells in these patients, they're very low. Usually it will be less than 300 cells per microliter that express CD3. So whether or not they have many B cells, enough B cells or enough natural killer cells, as long as there's a CD3 T cell lymphopenia, that is a SCID, okay? So SCID is more than one disease. It's not just one disease. There are many phenotypes that underlie this disease entity called SCID. The second group are combined immunodeficiency disorders that are associated with syndromic features, okay? So these ones are less severe than SCID, okay, in terms of manifestation. So SCID is, as I mentioned, is the most severe primary immunodeficiency. It's not compatible with life. Usually, if these children, it manifests in early childhood. If they don't get intervention in good time, then they're ultimately probably not even going to reach 1 year of age. Okay, so some of the combined immunodeficiencies with associated or syndromic features include thymic defects, for example, thymic aplasia, like DiGeorge syndrome. And as we know, the T cells mature in the thymus. So if, the thymus does not develop, that will interfere with maturation of your T cells. And DiGeorge is a syndrome because there are other congenital anomalies that are associated. For example, the heart defects, usually the parathyroids will be missing, so they'll have dysregulated calcium metabolism and things like that. Other defects or diseases that are under this classification include congenital thrombocytopenias. I won't talk much about them. Maybe you'll talk about them in hematology. So things like ataxia, telangiectasia, and Wiskott-Aldrich syndrome. There's an entity called CD40 ligand deficiency. If you remember your co-stimulatory signals that are important to activate, when you have antigen presentation to a T cell, whether it's by your dendritic cells or your macrophages or your B cells, you need a second signal. So the first signal will be MHC with the antigen interacting with the T cell receptor. Then there's a second signal. So usually it's B cells. Remember the second signals like your CD80, 86, okay? For your B cells, usually it would be CD40 ligand of the T cell interacting with the CD40 receptor on the B cell. I'll show you a picture just to bring this back into context. I think there's someone who asked me whether the second year immunology topics can be examined. Yes, they would, and most likely in an applied fashion. So you probably need to go and revise all your fundamentals of immunology, because now we'll be talking about the pathology associated with the immune system. So you really cannot know the pathology if you don't know the normal, okay? Hyper IgE syndrome is also one of the defects called a combined immunodeficiency. So this one, as the name suggests, patients tend to have very high levels of IgE, and they will present with a lot of, IgE associated pathology, like severe eczema, severe asthma, but they also have recurrent infections. So as much as they're producing a lot of IgE, there's underlying immune dysregulation when it comes to the function of their B and T cells, okay? I think there's one patient diagnosed here with hyper IgE. Okay, so a bit on SCID. Let me see, there's something in the chat. Which book do I recommend? I think there's a book, there's a recommendation on the timetable. I'll check if it's not there. I think there's several. If it's not there, then I'll tell Khan. Okay. So SCID, severe combined immunodeficiency. As I mentioned, there's more than one disease that phenotypically will be called a SCID. So one is reticular dysgenesis. So that just means you don't get your hematopoietic stem cell differentiating into the different cells of the blood. So there'll be no lymphoid development, no myeloid, no erythroid, no megakaryocytes. So, of course, if that occurs, you don't get any, the bone marrow will be aplastic. So phenotypically, these patients will not have B or T cells, so that will be a severe combined immunodeficiency. Okay. However, if you get an arrest at the common lymphoid progenitor, so the common lymphoid progenitor is what will give rise to your T cell progenitor, your B cell progenitor, and your natural killer cell, right? So there are several things that could affect this pathway of development. Some of them could be lack of certain enzymes. For example, one of the enzymes is called adenosine deaminase, so ADA. So this is an enzyme that's important in purine metabolism, okay? So if it lacks, so if the gene, the ADA gene is defective, then you don't get this enzyme being produced. So you get toxic, accumulation of toxic metabolites in these cells. So they die because of that, okay? They don't progress further. Right now, there's enzyme replacement available for patients who have ADA SCID. So it's possible to treat it by replacement of this enzyme, okay? The other group is the mutations in the recombinase activating gene. So if you go back to your ontogenesis, remember before at your pro B and pro T progenitor, okay, stage, for the receptor now to start being expressed, there's these genes that are switched on, the terminal deoxynitrodeotransferase and the recombinase activating genes, the RAG1 and RAG2, which are the ones that cause the gene rearrangement. And I'm sure you remember that the gene rearrangement is important for creating diversity of the B and T cell receptors, such that they're going to be able to, interact with virtually any antigen possible. And that's what gives us, that very specific and very diverse immune response that is characteristic of the adaptive immune system. So then if you don't have the RAG1 or 2 genes, then there will be no rearrangement. So ultimately, the pre-B and pre-T cell receptors will not be formed, okay? So if they're not formed, you're not going to get a mature B cell or a mature T cell, okay? So that's another phenotype of SCID. The other important gene, this is the one I was mentioning of the cytokine receptor gamma chain. So this is the common chain, this gamma chain. It's shared by interleukin 2 receptor, interleukin 7, interleukin 15, 21, and so forth. And I'm sure if you remember from your hematopoiesis, especially interleukin 7 is very important during the development and maturation of these cells. And we know for interleukin 2, this is the default interleukin that will be produced when a T cell is activated. And then it can come back and act on an autocrine fashion on that T cell to cause now further activation or even differentiation of other cells. And if you remember for cytokines, to have their effector function, they bind to their cognate receptor. So in this case, if the gamma chain of that receptor is dysfunctional, then you're not going to have a functional receptor, so you cannot get the function of these cytokines. So for the cytokines that are important in the early development of the T cells, then you do not get further development. There's an arrest at that point, okay? So that's how the SCID will manifest. The other thing is, the other disruption can occur at the stage of the thymic development of your T cells. So if you have any disruption with a pre-T cell receptor, such that you cannot get signaling that would lead to further maturation of these cells, then you don't get mature T cells developing, okay? So at the end of the day, it would just be a mutation in the genes that are responsible for this event. So mutation in the ADA gene, for example, mutation in the gene that codes for the gamma chain of these cytokines, mutation in the recombinase activating genes, and so forth. Okay, so phenotypically, okay, remember I mentioned that for those of us in the lab, to actually say a patient has SCID, there's going to be a severe T-cell lymphopenia. What marker do we use to identify these T cells? It's a CD3, okay? But we're calling this a combined immunodeficiency, meaning you can also have the B cells and the natural killer cells being affected. So usually when these cells are being enumerated, you don't enumerate the T cells in isolation, you also enumerate the B and the natural killer cells. And I mentioned the markers that are important. So for T cells, it's CD3, B cells, CD19 or CD20, and the natural killer cells, CD1656. And then, you can classify these disorders depending on the variation in the numbers of B and natural killer cells, whether they're normal or whether they're also reduced. T cells will also be reduced. So generally, there are 4 groups of SCID. All of them will have, low T cells, so hence the T minus. B cells can either be normal or low, so can either be B plus or B minus, and the same for natural killer cells. So that gives us 4 major groups of SCID. So majority of the SCID are actually the T minus, NK minus with normal B cells, okay? And you can see now the underlying gene mutation, okay? So the most common one would be the gamma chain of the cytokines being affected. And usually this would be an X-linked SCID, so would manifest in boys. Okay. I think that is what I will say about that slide. Okay. I mentioned some of the other combined immunodeficiencies that are less severe than SCID, but usually associated with syndromes, like the congenital thrombocytopenias. So this is ataxia telangiectasia is one group where the actual underlying pathology is a DNA repair defect. So if there's a DNA repair defect, of course, that will affect any cells. So even the immune cells can be affected, and that's why the patients would present with an immune deficiency. A balloon
in progress
with actual, it will be symptomatic, so with bleeding. And usually on morphology, on the peripheral blood film, they tend to have very small platelets. So, there's a standard size for platelets, and these ones would be very small, okay? I alluded to CD40 ligand deficiency. So remember I was telling you about your costimulatory signal that is important in activation of your T cells. In this case, the signal, the CD40 ligand and CD40 is important in the interaction of your T and your B cells. Okay, so you get your B cell presenting antigen to your T cell. Okay, so here's the antigen on being presented by MHC class 2, interact with the T cell receptor. So this is not enough to cause activation. You need a second signal. So usually the B cells also express a CD40 receptor, okay, which should interact with its ligand. So the ligand is expressed by your T cells, okay? So this would cause the T cell to be activated, and in turn it activates the B cells, and that's how you get your T-dependent antibody responses. Go back and revise your cell-mediated immunity in terms of T cell activation and your humoral immunity in terms of B cell activation. Read up on your T-dependent versus independent B cell activation, the differences between that, the importance of either, and basically the effector functions, what antibody isotypes will be produced, where do these occur. The T-dependent ones, if you remember, is what is responsible for giving us a germinal center reaction, and this is the one that will cause heavy class isotype switching of the heavy chain, okay? So if you don't have this response, then, your T-dependent antibody activation, there's no isotype switch. So usually, these patients who have a defect, either it would be the ligand or the receptor, would only produce IgM, Okay, they will never have an isotype switch to IgG or IgA or IgE. So if you evaluated them in terms of the serum immunoglobulins, that have very high levels of IgM and absent or low levels of the other isotype. So another name for this would be hyper IgM syndrome, but they've sort of moved away from that because they've seen that there are other conditions that can cause hyper IgM, but there's no defect in the CD40 and CD40 ligand. Okay. Remember the CD80, 86, and 28 was the other co-stimulatory signal that we see with the other antigen presenting cells presenting peptide to the T cells. Okay, so back to the classification. The third group are the predominantly antibody deficiencies. So here, as the name suggests, there'll be low immunoglobulin levels. So there are several diseases here. One is the hypogammaglobulinemia. And this can be classified into two groups. One where there are no B cells at all. Remember, I talked about the Bruton tyrosine kinase gene, where you get arrest of your B cells at the pre-B, so there'll be no further maturation. So of course, it's the B cells that produce antibody, okay? So in this case, B cells will be absent, but if you enumerate your B cells using flow cytometry, and you find that more than 1% of the circulating lymphocytes, usually majority of the lymphocytes in the peripheral blood are T cells, okay? But you find that B cells, are more than 1%, then that's another group of diseases, for example, the common variable immune deficiency. The other group here is the transient hypogammaglobulinemia of infancy. So as the name suggests, this is an infant who has a delay in, a physiological delay in producing their own immunoglobulins. So of course, when they're born, they have maternal IgG, which starts to wane from 6 months of age. By 9 months, it's almost completely gone. But you would expect, like from 6 months, they've started producing their own. So there's a delay in that. So they have that low serum immunoglobulins. Usually, for one to call a transient hypogam of in infancy, the cutoff age is, or rather, by 2 years of age, usually they have started producing their own immunoglobulin. The other groups could be the selective deficiencies, either of IgG, IgA, IgM. Okay, so I've already talked about the XLA, where you have maturational arrest at the pre-B. Talked about the selective isotype deficiencies. You can also have subclass deficiencies. Remember, IgA has 2 subclasses and IgG has 4. So either of those subclasses, any of those subclasses can be deficient. And this graph just shows what I was alluding to in terms of the serum immunoglobulins in a child according to age. So you have the age on the x-axis and the levels at the y-axis. So during pregnancy, you get transfer of maternal IgG, which peaks in the 3rd trimester. So at birth, you expect it to be at its peak. So preemies, premature babies, they'll obviously have low IgG because we have, you've interrupted this period of time when they should be having majority of that maternal IgG being transferred. Okay, so at birth, they have peak in IgG from the mother from about 6 months of age. You get a very low level, but you expect that they have started producing their own IgG, okay? So by 9-10 months, they should be producing their own IgM, their own IgG, their own IgA. So sometimes there could be a delay in this process where you start getting the peak maybe from 1 year onwards. So that's why it's called transient, because it resolves with time. So the common variable immunodeficiency, this is another group of disorders where there could be more than one defect. They don't really know, they haven't pinpointed to see this is the gene defect. But what happens is that, most of these people who present with CVID will be relatively okay. But then as they grow older, they start having recurrent infections or recurrent inflammatory disorders, especially gastrointestinal disorders with malabsorption. And then on evaluation, immune evaluation, they find that they're having abnormalities with immunoglobulin. Okay, so they tend to have low immunoglobulins. So it's not really known, whether there's a late arrest in, the B cell production. Remember, B cells are produced throughout life, unlike the T cells. Okay, so it could be something that comes in later, or is it impaired regulation of your T helper cell? So it's not really known. So this CVID is the important disease that can manifest in older childhood or in adulthood for the first time. Usually it is not diagnosed before 4 years of age. Okay, so there are very many causes. Sometimes, there's a delay in picking it up. You just have a person presenting with recurrent, especially pulmonary infections. Remember the effector functions of antibodies and the fact that antibodies are very important in providing immunity to extracellular bacteria. So they tend to have recurrent pneumonias, and if it's not picked up in time, and they're given replacement immunoglobulin therapy, then they can end up with end organ damage, which usually would manifest with bronchiectasis. Okay, so there's more than one cause of CVID. It's quite common, okay, in comparison to, for example, kid. And then the phenotype, the presentation clinically is not going to be the same in patients. A lot of them also tend to have autoimmune diseases, especially the autoimmune cytopenias, like like ITP or the autoimmune hemolytic anemia. Okay, so they have a lot of autoimmune manifestations. The other group are the diseases of immune dysregulation. I won't go into much details of that. As the name suggests, there's dysregulated immunity. So this includes things like, these ones are very rare, like hemophagocytic lymphohistiocytosis. And there are other syndromes that occur with autoimmunity. For example, the autoimmune lymphoproliferative syndrome. So as the name suggests, are patients who present with both autoimmune disease and lymphoproliferation, okay? There's also, if you remember these two genes from your T-cell ontogenesis, the FOXP3, remember FOXP3 is an important transcription factor, which will be expressed by the T regulatory cells, okay? So a mutation in that means, as the name suggests, there's no immune regulation. So these patients present with autoimmune disease affecting more than one endocrine organ, as well as enteropathy, and it's X-linked. So that's where the abbreviation IPEX comes from. Remember the autoimmune regulator gene, which is the one that will be switched on such that as the T cells are undergoing the thymic education, and you're going to have the thymic epithelial cells expressing self-antigen, so that you can have a negative selection such that the T cells that interact with MHC that is carrying self-peptide, those that bind strongly are going to be deleted clonally, okay? That is where the IRA gene is important. So of course, if there's a mutation, then you don't get proper negative selection, and that's how these patients end up with the Apesed syndrome, okay? The other group are the congenital defects of phagocytes. This can be the phagocyte numbers or the function or both. So in terms of numbers, you have the congenital neutropenias. There's one we diagnosed this year of a 4-year-old girl who had recurrent neutropenia with recurrent skin infections that were very severe. So she had a mutation in, there's a gene called ELANE gene, which codes for one of the proteases that is found in neutrophils, the neutrophil elastase. So that's in terms of number. In terms of function, this basically just means, either the neutrophils cannot come to the sites where, for example, your microbe is, okay? So this would interfere with neutrophil chemotaxis and transmigration from the blood to the tissue. So the leukocyte adhesion defects. And then the other defect that would affect the function would be something that affects the killing. So maybe a defect in some of the enzymes that are involved, like the myeloperoxidase, or the NADPH enzyme system, okay? So this would be the chronic granulomatous diseases. The sixth group are the defects in intrinsic and innate immunity. These ones are not very well defined, but in terms of the phenotype or the clinical manifestation, either the patients will be predisposed to invasive bacterial infections. So an example is a patient who's born without a spleen. I guess that makes sense because, the major function of the spleen is to produce antibody, and antibody is important. In immunity to extracellular bacteria, it's also an opsonin, so important for immunity against capsulated microorganisms, okay? So that, it opsonizes them so that they can be phagocytosed. Another group would be those who are predisposed to parasitic infections. For example, ApoL1, if you've gone through your nephrology series, maybe this was mentioned to you. So this ApoL1 gene provides resistance to, if you have any mutations in this gene, or rather, this gene is supposed to help confer resistance to trypanosomiasis. So people who have mutations in this gene tend to be predisposed to trypanosomal infections. The importance in nephrology is that they also tend to be predisposed to kidney disease. Okay, and I think this was really discovered in the era of the new days of HIV/AIDS, where people would present with HIV-associated nephropathy. Amongst Africans, it was found that a lot of them expressed some abnormalities in the ApoL1 gene. Interleukin-17 is important in both extracellular and bacterial bacterial and fungal immunity. So patients with a defect in that gene would be predisposed to fungal infections. The other disease entity is Mendelian susceptibility to mycobacterial disease. So as the name suggests, abnormality in the pathway that is involved in, activation of your macrophages so that we can get rid of mycobacterial infections would predispose to MSMD. I'll show you just a picture of that pathway. And then there's another group with predominant susceptibility to viral infections. Okay, so this is just to summarize the quantitative neutrophil defects. So of course, phenotypically on a hemogram, these patients will have neutropenia. Secondary neutropenias are more common, so that is what you would want to rule out, okay? Whether it's immune-mediated, whether it's due to drugs, whether it's due to infections, and so forth. If you rule out all those, then now you'd want to think of a congenital neutropenia. So for the leukocyte adhesion defect, remember with the rolling and margination and rolling rather, of your leukocytes, that is important so that they can transmigrate, which is facilitated by interaction between selectins and integrins on the endothelial cells. So if you have these proteins missing, then this would interfere with the rolling of your cells, okay? So that's the disease entity known as the leukocyte adhesion deficiency. So they cannot migrate from the blood to a site of infection. So usually these are patients who will have, they have deep abscesses, but they're sort of like cold abscesses. They're not, you're not getting, your pus formation because you don't have your neutrophils coming to the site. And at the same time, they tend to have very high white cell neutrophil count. So they have neutrophilias. It's that these neutrophils are not going where they're needed. Okay. For the chronic granulomatous disease, here the defect would be within the enzyme system or the oxidative killing mechanisms. So yes, your neutrophils can migrate to the site, but they cannot kill the pathogens. Okay. There's also Chediakigashi, which Prof. Mwanda usually likes, where you have your neutrophils having very large abnormal granules. For the MSMD, so this is the pathway that is important for, this is, remember your type 4 hypersensitivity pathway that leads to activation of your macrophages so that they can get rid of your mycobacteria. So what you have, once you have remember your mycobacteria will cause intracellular infection, so they can infect your phagocytes, or your phagocytes can take them up, and they would want to, take up some of that peptide and present it to the T helper cell, okay? So you get, as they're, presenting that, they also secrete interleukin-12, okay? Which acts on its receptor on the T helper cell. The T helper cell responds by producing interferon gamma. Interferon gamma, if you remember, is the one that activates your macrophage, okay, then it enhances its capacity to kill. So any mutation that affects this pathway, whether it's, you have a defective gene for interleukin-12 or its receptor, okay, all these intracellular signaling molecules like the tyrosine kinases that are important, or if you have a defect in the gene for interferon gamma or its receptor. So anything that interferes with this pathway would now mean you cannot properly activate the phagocytes, the macrophages, okay, so that they cannot get rid of the mycobacteria. Inherited in a Mendelian fashion. That's why it's called Mendelian susceptibility. We don't know how common this is in our setting. South Africa have done quite a bit of work on MSMD, and they're finding that, it's there, as well as West Africa. For us, we say TB is endemic in sub-Saharan Africa, but how much of that endemicity is because of MSMD, we really don't know. These are the other groups, so the autoinflammatory disorders. So here, they're just patients with dysregulated inflammation. Most of these patients will present to rheumatologists. They're rare. Then the complement deficiencies. This means you need to go back and revise your complement and the activation pathways, biological effector functions, the regulation of complement as well. So the deficiency could either be to the complement components, the proteins, or the regulatory proteins. Bone marrow failure was added. I think it was added in the 2017 classification. So there's an overlap here now between immunology and hematology. Of course, if the bone marrow has failed, you don't have your immune cells. That's straightforward. So any of the bone marrow failure syndromes, okay, that you'll cover in hematology. And then this other last group is quite interesting. These are the phenocopies of PID. So they're called phenocopies because phenotypically they present similar to a PID, but the mutation is not a germline. Either it's a somatic mutation or there's an autoantibody that interferes with some of the immune functions. So that's why it's called phenocopy. Like the phenotype is similar, but the mutational defect is not inherent to the immune system. Okay, this is an example of a defect in a complement regulatory protein, and I think this one is also mentioned in hematology, the paroxysmal nocturnal hemoglobinuria, where either we lack the CD55 or 59, so the decay accelerating factor, if you remember that, or the CD59, which is protectin, which should be expressed by normal cells, okay? And that is what now prevents insertion of the membrane attack complex into normal cells. So your microbes, for example, will not express this, and that's how the mark can be inserted on them, and then you get lysis of the cells. So if you have cells, especially red blood cells, that are lacking either CD55 or 59, then you can get insertion of MAC and you get lysis of the cells, and that's how these patients present with hemolysis, okay? The other complement deficiencies, usually we group this according to the group of proteins, whether it's the early complement proteins, especially for the classical pathway, or the late components. So the early components, we know, are C1, the C1, okay? So interestingly, C1q, C1r, and C1s, when there's a defective gene, and I think also might include C2, these patients tend to present with immune complex mediated disease, okay? Go back and read your type 3 hypersensitivity and just revise how we get rid of immune complexes. But remember, when we have immune complexes, they activate the classical pathway of components, and this is the first component, the C1, with its 3 sub-proteins. So these patients will present with a type of SLE, but they're also going to be predisposed to infections with pyogenic bacteria. You can have a defect in the regulatory protein, which is the C1 inhibitor. These patients present with hereditary angioedema because this C1 inhibitor also regulates the bradykinin pathway. Okay, so the angioedema is just because, it's not because the complement is not being regulated, but because you get excessive activation of your kinase system. And that's why these patients get edema. We have one patient, one Kenyan patient, and she's very, she's creating a lot of advocacy. One Kenyan patient with HAE, that's hereditary angioedema. For the C2 and C3, majorly, they may have the immune complex mediated disease because they cannot get rid of immune complexes, but majorly they'll present with pyogenic bacterial infections. For the late components, remember these are patients who will be susceptible to recurrent ministerial infections. Okay, it looks like I'm not gonna finish today. Let me see where I'll stop. Okay, maybe I'll make this my last slide. It looks like I might have to, I'll see if I can get away from the conference and complete this lecture tomorrow at noon. I just wanted to highlight this. Remember the last group with the phenocopies? This was discovered last year. And I can't remember whose work this is. I don't know that this is the Casanova group. There's a guy called, a French immunologist called Casanova who discovered this, but I think other people have also replicated this. They found that, so remember for the phenocopies of the PIDs, either it's a somatic mutation or autoantibodies. So they found that people who, some of the patients who get very severe COVID-19 actually produce autoantibodies against the type 1 interferons. So remember the type 1 interferons, interferon alpha and beta, are the ones that are very important in the early innate immune response against viral infections, the ones that cause an antiviral state, so that, if you have one cell infected, the neighboring cells and that cell actually also produce interferons, which either interfere with viral replication or interfere if you get the virus now budding out, it's not going to infect the neighboring cells. So this has been found as evidence for very severe COVID-19 in a subset of patients. So that's a phenocopy of a PID. Okay. All right, I'm going to stop there. So tomorrow we'll pick up from here, the distribution. And then we'll talk a bit about the evaluation. I think on the lecture on 26th on, on approach to the immune deficient patient, I'll focus more on the laboratory immune evaluation. Okay. If I'm not able to catch up with you tomorrow, maybe I'll do everything on 26th. But tentatively, we should pick up from here tomorrow.
Okay, doctor.
All right.
Recording stopped.
I had a question.
Yes.
In regards to the cat.
Mm-hmm.
I understand that it is 150 marks and that immunology will comprise of 25 marks. Is that true or?
Yeah, so anatomic path has 2 essay questions, hematology has 2 essay questions. An essay question totals to 25 marks, whether it's short answer or a full essay. So Heme has 2, AP has 2, ClinChem has 1, immunology has 1. Yeah, so 50-50, 25-25.
Okay, that's good. Thank you so much.
All right. Okay.
I also had another question in regards to your lecture.
Mm-hmm.
You said, like in other deficiency, you said that nowadays people are getting the enzyme replenished. How is that actually happening?
Enzyme replacements. Okay,
Yeah.
I don't have exposure on how it's done or how it's given. Maybe I'll look at that and see if I can send you that info. Okay. I don't know of anyone doing it in North Africa, because I know there's a lot of kids in North Africa, but for them, they would rather do either bone marrow transplant or what's the other thing? Gene therapy. So for the enzyme replacement, I'll try to look that up and see exactly how the enzyme is delivered into the system.
All right. Thank you so much, Doctor.
Okay.
Have a good day.
Okay, you too.